Welcome to the Woodland, everyone. It's a pleasure to welcome you to our April Elf Campfire. And the question we're asking this month is, what has qualitative research ever done for us? This debate has been sparked by feedback from reviewers at the BMJ who wrote a rejection letter in September last year saying that qualitative research was, and I quote, low priority, unlikely to be highly cited, lacking practical value, or not of interest to our readers. The discussion that followed this mini revelation has been instructive and constructive. It's led many of us to think again about the relevance and importance of qualitative and quantitative research, and it's inspired us to have this discussion. My thanks go in particular to Tara Lamont, who first suggested this campfire topic, and I'm delighted to say that Tara is with us today, alongside a number of other experts from the world of mental health qualitative research. Over the next hour, we'll be sharing our experiences, celebrating the achievements of specific qualitative studies, and discussing the challenges facing the field. As usual, you can join the debate on Twitter using the hashtag #ElfCampfire, and Douglas has his mental health hat on today, so he'll be around to respond to your comments on Twitter and relay your questions to our panel. So I'd like to start by inviting everyone to briefly introduce themselves and tell us about their relationship with qualitative research. So Tara, this was your idea. Would you like to start? Hang on a second, Douglas will just unmute you. Or maybe you can unmute yourself. Okay, we're having a little technical problem, so everybody needs to unmute themselves. If they could do that before they speak, that would be great. You do that by putting your mouse over the video window and then clicking on the mute microphone button.
Yeah. So I'm Tara Lamont. I'm here today really as scientific advisor to one of the big NIHR programs on health services research, and we commission, we're sort of non-denominational, I think, as to methods. We commission quite a lot of qualitative research, and I'd like to, share some of the experience of what those studies have added to our knowledge base and how distinct they are, perhaps, from other forms of research.
Great. Welcome. Thanks very much, Tara. Thanks for joining us. We've got Professor Alan Simpson and Professor Emer Muir-Cochrane who are joining us, both from the same connection. So over to you, Alan and Emer. Would you like to introduce yourselves?
Yeah, sure. Hello, I'm Alan Simpson, Professor of Collaborative Mental Health Nursing at City University in London. I've been using qualitative research methods for about 20 years probably. Sometimes solely qualitative, but increasingly as part of a mixed methods approach to research.
Great, welcome.
Emer Muir-Cochrane. I'm a Professor of Mental Health Nursing from Flinders University in South Australia and a visiting Professor at City University with Alan's Research Centre. My interest in qualitative research, I suppose, has come from the very personal, intimate nature of people's experiences with mental health and how to capture that in a meaningful way.
Great, thank you, welcome. And that's not an Australian accent?
No, from Leeds originally.
Excellent. Well, thanks for joining us. Great. We've got two colleagues from Manchester, so Professor Stephen Primichik and Sarah Knowles joining us. So Sarah, over to you.
Yeah, hi. So I'm Sarah Knowles. I'm a jobbing researcher. I'm a research fellow here in Manchester with the Greater Manchester Collaboration for Leadership in Applied Health Research and Care. And for the past 9 years I've been working in health research and doing predominantly actually mixed method studies, and a lot of my qualitative work has been nested qualitative studies within trials. So I'm sort of particularly coming from this angle of I really see that those things can be very complementary, and the fact that to get a whole picture in health research you're really looking at a combination of those methods and what qualitative can add to that. So that's my soapbox.
Thank you. It'd be really interesting to pick up on that, maybe talking about the REACT study, for example, later on in the discussion. Sarah's also a frequent blogger on mental health. She's blogged a lot for us over the years. And Stephen, yeah, can you introduce yourself, please?
Hello everybody, I'm Stephen Primatuk. I'm Professor of Mental Health Nursing in School of Nursing, Midwifery and Social Work at the University of Manchester. And I'm a little bit of an interloper here because I'm primarily a quantitative researcher who has been converted, for want of a better term, by working on mixed methods projects with some outstanding qualitative researchers. So I've actually got a real interest in qualitative research, and I have been conducting some qualitative research, and some of my colleagues inform me that I'm doing it okay, but I perhaps don't have the confidence qualitative methods that some of my more experienced colleagues would have.
Great, thank you for joining us. And finally, Trish Groves, Head of Research at the BMJ, is joining us. Trish, would you like to say hello, introduce yourself? We can't hear you. You need to unmute your microphone.
Hi.
Yes, great. Hi Trish, we can hear you now.
Got me. Can you see me as well? Do you want video?
Yes, perfect. Hello.
Okay, great. Hi, hello. So I used to be a psychiatrist. I've got MRC Psych. I was a psychiatrist before I went to the BMJ, but that was a hell of a long time ago. I've been there 26 years. So I'm head of research, and I've accepted and rejected thousands and thousands of papers over the years. I'm sure you'll be having some questions for me about BMJ's position on this, but for now I'm really here to listen.
Great, thanks a lot for joining us. So we are hoping that 2 or 3 other people can join us. Ben Hannigan, Michael Coffey, Sarah Carr are also on the list, so hopefully they can join us at some point over the next hour. But let's kick off with the first question, and this is just an informal discussion really. We're not going to ask specific questions to specific people, we just really want the panel to respond generally to these 4 questions that we have. The first one is, why is qualitative research considered to be less important than quantitative research? I asked this question on Twitter a couple of days ago, and I got lots of people saying it's not, actually. But I think generally that's the sense that I sometimes get in mental health. Who would like to kick off with a response to that?
Go on then, I'll kick off.
Thanks,
Alan here, yeah. I think that the dominant view for a long time was that qualitative research was too subjective, whereas quantitative approaches were meant to be pure science and a more objective way of doing things. It was more difficult to replicate qualitative research. They were seen as more prone to bias and influenced by the researcher, and I think a fear sometimes that people became too close to the data and the people they were researching, and losing what was seen as a necessary objectivity and distance. I think all that's largely not so, but I think that was for a long time a dominant viewpoint.
I think too, one of the perceived problems is the difficulties of generalizing across a number of studies. And as Alan was saying, in a way, in experimental studies, you're trying to bracket out the effects of context and the particular circumstances. With qualitative studies, you're kind of embracing that, but it does then make it difficult to, I think that the critics would say, to kind of do more than just collect together a few anecdotes, a few descriptive studies of what happened here, and to make it into something that is robust. I think the great strength of qualitative research is the fact that it does pay attention to and understand the context-dependent nature of most practice, and that's true in mental health. So I hope we can explore that a bit more during this discussion.
I think if I can jump in, I think so. As someone who's worked a lot on trials, I think there is a view as well that sort of qualitative research, it's very nice to know these stories about what patients think, but fundamentally, the big question of does it work? Does it you know, at the end of this, does a person who gets this treatment have a lower depression symptom scale than someone else? The idea that actually it's the quantitative studies that give us those big answers that are going to, you know, improve patient care or get into the nice guidelines and that kind of thing. And I guess my response to that would be that, well, from you know, all the time I've spent blogging for the mental health, there's very rarely a sort of a trial or a study that gives you any kind of a lovely definitive answer like that. Often they are kind of just little pieces of a puzzle. And actually, you know, I'd argue that a lot of the time qualitative studies give you, you know, I can often read a qualitative and it has a very strong message that comes out of it that you can go quite confidently, that is what this tells us, in a way that often actually I think quantitative studies don't give us that.
Can I chip in?
Please do.
Yeah. All of that I absolutely agree with. I mean, I've been at the BMJ so long that I commissioned, I think, the 2 series that we had on how to do qualitative research way back in the 90s, rather, which were really helpful because it was bringing the world of qualitative research, which up until then had been in social science largely, in front of a sort of general medical audience and a general medical research audience. And I don't think anything we've said over the last year, I hope, should undermine our respect for qualitative research done well and its place. But I think what people perhaps, there's 2 things perhaps people don't quite understand, and that's that journals vary a lot. They have their different niches, and we have, I think, always made it pretty clear that the BMJ tries to be pretty close to sort of close to practice and policy, and we try to publish research that's kind of cooked. So we don't publish, for instance, the regulatory trials against placebo, which you will find in specialist journals or in the New England Journal or the Lancet, because they're kind of close to the translational lab sort of end of research. They want the cutting edge stuff. Arguably, they ought to be publishing the really important qualitative studies, but you should have that fight with them. We're trying to publish kind of definitive, reasonably definitive work, which is pretty generalizable across many countries, healthcare settings, and so on. That's why you'll see that we don't publish much, for instance, UK health services research anymore either. We also audit all the research that we publish, and we've been doing this for a decade. So we look at hits, downloads, pickups, you know, the whole thing, as well as rapid responses and sort of general buzz. And we look at pickups in evidence-based medicine services. Now, you may not expect qualitative research to appear there, but you would hope and expect it to be read and shared and responded to. And for 10 years, we found that qualitative research has just fallen completely flat with our readership in comparison with every other kind of research design that we publish. So we have gradually got tougher on the studies that we're willing to consider, because if we're only going to publish 5%, we want to publish the research that is most apparently useful to our readers, and that's just the reality of it. And being the BMJ, we're perhaps a bit too honest, so when people started asking us why, we started explaining, and that has upset a lot of people. So this is not supposed to be a sort of apology. I hope we've made our position really clear. We think there's a really important place for qualitative research, and we provide many places for that to be published across our 60-something journals at BMJ, in many of our specialist journals, and particularly in BMJ Open, where we publish a lot of very interesting qualitative research. Although I do note that even there, it's very rarely read and downloaded in comparison with other studies. So I don't know what's going on, and that is a bigger question. But in terms of the BMJ, I don't think there's anything to defend, and I'm sorry if I sound defensive, I'm trying to explain. It's just kind of not where we are as a journal.
Can I just say something, which I think is slightly ironic, actually, because I was trained originally through psychology and had no contact with qualitative methods at all until I entered nursing and got exposed to some very good teaching from the department that I did my master's degree in. But one of the things that made me think really, really deeply about qualitative methods was, ironically, an article in the BMJ many, many years ago, where I can't quite remember who authored it, and you may remember this yourself. It's where somebody had gone out and asked patients what they thought randomised meant in a randomised controlled trial, and the findings were absolutely fascinating. It made you realise that if you're looking at something like, I suppose, as hard and supposedly objective as a trial, there are some other elements to it that people who are conducting trials often didn't think about.
Yeah, absolutely. There's a really important a part for qualitative research in understanding what's going on in trials, in helping recruitment to trials, all sorts of things like that. And nobody's pretending that trials are perfect. We know that there are all kinds of problems with trials, and we're publishing lots of stuff on all the problems with trials. Anyway, I'll stop for now, but absolutely I understand the arguments. We've just got this rather sort of practical approach that we want to publish research that is most used by our readers. There is also this issue of impact factor, which we're not in love with, but whether we like it or not, our authors care about it enormously. And we know in survey after survey and study after study, when you ask people, why do you choose a journal? Is it because of the audience? Is it because of open access? Is it because of this, that, and the other? And they always damn well put impact factor first. And qualitative research, you know, we were only publishing maybe 5 or 6 studies a year. That's a drop in the ocean in terms of our impact factor. That doesn't really matter because other things are cited very, very well. So that's not the reason exactly. In fact, it's not the reason at all. But I can understand why people think it might be.
Okay, thank you, Trish. It's really good to get the explanation straight from you. I'm sure we can cover that in a bit more detail as time goes on. Sarah Carr has joined the call. Welcome, Sarah. Great to see you.
Hello, Andre. Thank you.
We're going to start talking about some kind of landmark qualitative studies now. I'd like you, maybe it'd be great if we could highlight sort of 3 or 4 key mental health qualitative studies from the last few years. Sarah, have you got a study you would like to tell us about?
I do. I've got a couple. Sort of my background is more social care research. So we've kind of got the inverse issue with there aren't very many RCTs in social care. So that was an aside. But for a landmark study, again, sort of another bit of my background is service user research and the use of experiential knowledge in research as well. And I'd say probably the Strategies for Living project that was funded by the Mental Health Foundation in 2000 and carried out by Alison Faulkner. And that was a kind of pioneering piece of user-led research. It was qualitative in nature, and it actually just went that they went out and asked people what helped them manage their mental health condition, how they live their lives. So stuff that really wouldn't appear in any kind of clinical study, but elements in people's lives and the way they lived, which actually helped them manage their mental health problems. Evidence which is quite valuable now in the policy context where people are thinking about self-management, prevention, personalisation. But I really wanted to talk about Diana Rose's study from 2003-2004 on patients' perspectives of ECT. And I think this is a really interesting study because it kind of set up a conversation between service user views, and it was a user-led qualitative study, but it was a conversation with the clinical research that had been carried out about ECT, which showed the positive benefits of ECT. But there appeared to be, at least to the researchers who carried out the study, maybe some gaps, some things that were appearing in service user testimony and people's experience of receiving ECT that hadn't been captured in some of the kind of standard questionnaires. And they interviewed a lot of people, about 130, 135 people, and looked at other forms of testimony about experiences of ECT. And they found, you know, people had negative and positive experiences of it. But what was coming through was experience of persistent memory loss. But this wasn't actually being picked up in some of the clinical studies. So I found that that's kind of, for me, a landmark study where user-led research and qualitative research was looking at service user experiences that hadn't actually been picked up in some of the clinical studies, but were very, very important to achieve some kind of for informed consent. Because persistent memory loss seemed to be one of the risks of ECT as a treatment.
It's a really nice example. And how did the community of clinical researchers who were doing the ECT studies and practitioners using ECT respond to that evidence?
I think there was some sort of debate in journals, but eventually I think the worth of the finding was recognised, particularly in the context of improving informed consent.
Yeah.
This is the point about user-led research, which I guess is something that was quite, around that time, around 2000, that's what then was really kicking off in mental health research. And obviously service user involvement in research generally, not just qualitative research, is now considered really key. But has qualitative research really trailblazed in that sense?
I think I was really interested that Sarah picked out the strategies of living report, because I was working in Brighton then, and I remember going up to the launch of that report in London, and it blew me away, and it was one of the key pieces of work which influenced me as a researcher and recognised the importance of user involvement and having service users central to the research. And it's a great privilege that I now work with Alison Faulkner, and it's been an interesting journey. And similarly with Diana Rose's work, massively important. And previous to the ECT work, her work around user-focused monitoring, which used qualitative research methods. Very, very important, influential stuff around changing our views about the ability of service users to go out and conduct research and inform our understanding and our practice. But in my own world of mental health nursing, there have been not so much landmark, but probably some fairly small studies which were important and influential for me. Alan Quirk's fantastic ethnographic work, where he went in as a researcher, spent time on acute inpatient wards, observing what was going on, writing about that, and identified some of the strategies that service users, patients employed to keep themselves safe in what are often quite volatile and unsafe environments. Massively important piece of work, and beautifully conducted and written. And similarly, Joy Bray, who was really intrigued and interested of why do we get these reports that mental health nurses on wards are hiding away in the office, in inverted commas, and not engaging with patients. And she went and worked as a care assistant on wards and observed and spoke to people and listened, and she reported about the massive emotional impact of doing mental health nursing work, day in, day out, working very closely to people who were very unwell, very disturbed, and very upset, and the impact that has on you as a practitioner, leading to the necessity to sometimes withdraw from the fray. And if that isn't managed, and if people aren't supervised and supported, it can lead to them withdrawing totally, practically, physically, but also emotionally. Massively important work to help us think about how do we ensure we maintain good mental health nursing practice. And I don't think you would have got those sorts of insights from any quantitative research.
Thank you, Alan, that's great.
It's just Dima here, just to build on that. It's not a mental health study, but the Isabel Menzies work in the 60s looking at social system as a defense against anxiety actually helped, because it was so psychologically, theoretically informed, really helped mental health nurses then look at how practice impacted on their own emotional state, and how some of the what to us in the 70s and 80s seemed absolutely ridiculous nursing practices that were very controlled were in fact were ritualized behaviors to protect the emotional safety of nurses doing very intense immediate care with people. So that study to me was formative in my going into undertaking mixed methods research, but also understanding how potent qualitative research could be.
Thank you. Tara, can you share with us some of your favourite studies?
Yeah, I mean, like Alan, I've been very influenced by some of the observational work, the kind of careful, close ethnographic work. In fact, one of the interesting ones from the NIHR portfolio is by Justine Schneider on care and dementia wards, where unusually actually it was participant observation, so researchers working as healthcare assistants on dementia wards. And I think in that kind of deep way, one of her findings was how important the nursing support staff were for, as she calls it, managing the emotional climate of the ward, particularly when there was challenging behaviour. I mean, another study that comes to mind is John Gladman's study. Again, this is actually a lot of the studies I was looking through the NIHR portfolio. A lot of the studies around dementia and care of older people with mental health problems. And John Gladman's study, which looked at 2 trusts and did, again, a lot of, it was mixed methods, as many of these studies are, and just looked at the way in which old people with confusion are managed in the system, not very well at times, and identifying the kind of core problem of the sort of major disruption for the patient and with dementia in coming to this alien environment. And that's something that's been picked up latterly on sort of campaigns about carers accompanying patients into hospital. I think the other way that qualitative research can help is in looking for kind of positive deviance. And I was thinking of Michael West's work in sort of shadowing high-performing multidisciplinary mental health teams and just trying to unpack, you know, what are the features of teams that work really well, and trying to sort of dig under this, you know, the kind of poorly understood things around team cohesion and behaviours. And then perhaps the last study I would think about was, well, I was thinking of Diana Rose's work too, but also Jill Manthorpe's work on the transition for people with memory problems to dementia and what the consequences are for identity and selfhood and status. So I think many of these studies are, they may be solely ethnographic studies, they may be part of a mixed method studies, but without understanding the experience, the hows and the whys, you know, I don't think that we can really understand our complex systems and practices.
Yeah, absolutely. Thank you. So Tricia's explained a little bit about the BMJ's position now on qualitative research and all the other BMJ journals as well. What's the NIHR position on this? You're obviously funding a lot of mental health research, a lot of other research. Do you have a position on qualitative and mixed methods, and how does that work?
Yeah, I mean, certainly the programme I know the most about, the Health Service and Delivery Research Programme, commissions a lot of qualitative research. I think the more typical, particularly for evaluations of services and systems, is a mixed method study. But I think, as pointed out by Trish Greenhalgh and colleagues in their letter, the Health Technology Assessment Programme is you know, it is promoting much more strongly the importance of process evaluations. In fact, the MRC have just produced some useful guidelines on process evaluation to understand how acceptability and the appropriateness of interventions as they are implemented is a key part of most clinical trials now.
Great, thank you. So Stephen, Sarah, you haven't responded yet in this little segment. Have you got anything to add to this list of great mental health qualitative studies?
Well, I don't think I can add anything to that, but I wanted to pick up on quite nicely on something that Tara had said, because I had a project that was funded by the NHIR, which I think made me realise just how important qualitative perspectives are in terms of health services delivery. So I was involved in a PI on a project looking at self-management and children and young people's mental health problems, and we actually did mixed methods. To an extent, we did a full evidence synthesis and meta-analysis, and there's no great surprises in the meta-analysis because all the effective interventions are parenting interventions or largely CBT-based interventions. But we coupled that with significant case study research where we went out and spoke to children, young people, their families, people who delivered the services. And the fundamental theme that came from the children, young people and the families is that they wanted choice and flexibility with the interventions that were offered to them. Yet what the effectiveness data is saying is you don't get any choice, you get CBT or you get parenting, because that's they're the effective interventions. And you also get no flexibility because they're all manualised. So you've got to adhere to the manual and you have to have them delivered in this particular way. Interestingly, then, when you talk to the people who deliver the interventions, they say, well, we know we're supposed to stick to the manual, but if we do what the manual tells us, we never keep these people in the interventions. So we have to use our skills as mental health professionals to sort of skirt around the demands of the manual just because we think it's really important that we keep these people in the interventions that we're there to try and help them in the first place. And if you just look at the effectiveness data, all you're doing is getting one side of the story, and it's not particularly helpful when you're looking about how to design services for people with mental health problems.
Thank you, Stephen. That's really interesting. Sarah, anything to add before we move on to the next question?
I guess a paper that I sort of particularly think is a great example of sort of what I said about actually it can be sometimes qualitative studies that give us these really strong messages that drive things forward. There was a paper by Pete Coventry and Caroline Graham called Talking About Depression, and it was about how GPs talk to their patients or don't talk to their patients about mental health and depression particularly, and it just has a really solid set, I think, of recommendations about, look, this is what we need to overcome. These are the issues about what happened. It talked about, the pressure on those services with things like quality and outcome frameworks and how that was limiting maybe what GPs could do. The issue that these were people with long-term conditions, and so there was a kind of relationship where GPs might be normalising the mental health problems they were experiencing. It just really kind of solidly, I think, said this is what we need to overcome in primary mental health care, and it actually won them an award from the RCGP for Best Mental Health Paper, which I think sort of shows that they were recognising as a piece of qualitative research the contribution it made. The other point I was going to mention is perhaps more, I think as someone's already said, I don't quite like this idea of saying what a landmark study is, because I think we make progress in studies rather than this idea we get these definitive answers. But actually I think really interesting for qualitative research is the increase in meta-synthesis and meta-ethnography. So basically as a way of synthesizing qualitative data together. And there was a paper by Alice Malpass and David Kessler at Bristol, which did that around patient experience of taking antidepressants, and was just a really nice way, I think, and really points to perhaps where a future way of using qualitative research by synthesizing these studies together to give us very solid messages about how we need to approach care and how we need to better help people with mental health problems.
These systematic review methods have been around for a while, haven't they? I know that Cochrane have had systematic reviews of qualitative studies for a while. But so what are the challenges there? Does that feed back to the qualitative researchers in the sense that they need to be doing their studies differently so that they can then be included in a systematic review and pulled together in that way?
I think certainly you know, I think there has been, as I've seen more metasyntheses published, I think I've seen more of the debate around should we address quality in qualitative research, for example, and what quality means in qualitative research. And that's a debate that I think more learned people than me would probably need to answer. But I do think that I think those kind of things are quite good. I think you know, if you've already got your eye on sort of reporting things in a way that is going to be most transparent and most useful to people, then I think that's always a good thing.
So that leads on really nicely to our next question, which is how can we weed out unreliable or irrelevant qualitative research? And I guess I'm thinking this from the perspective of somebody who is reading a piece of qualitative research and trying to work out how to assess the quality of it, but also thinking about, you know, publishing it. So from the perspective of a journal editor, how do we decide what's good and what's not good? So there's a number of different criteria that we need to look at there. The kind of critical appraisal checklists that exist, but I guess the inclusion criteria that you might have in a journal. So yeah, who would like to make a start on answering that for us? Don't all shout at once.
Well, I can make a comment just because I've been involved in many systematic reviews. I mean, which both systematic reviews of effectiveness, so it's largely looking at trials, but also reviews looking at qualitative papers. And I think there's two elements when you're looking at quality. Really, it's about the quality of the actual study itself, how it's carried out, which I think is slightly more difficult to deal with. And then there's also the sort of the textual quality, the way in which the paper's written itself. And one of the things that and those who are more experienced qualitative researchers than I am can shout me down on this one. One of the biggest issues I have with papers is that they're sometimes completely unintelligible. And I think there's, you know, to some extent it's more common in qualitative papers than it is in quantitative papers. I'm certainly not saying there aren't, you know, trials that have been reported that are unintelligible, but, you know, I think, you know, if you're going to try and make some comments about the quality of papers in general, you've got to be able to understand what those papers mean. And, you know, part of it is about who you're writing for. Are you writing for an audience of academics, or are you writing for the public? And I actually, my own personal view is I don't think it matters. You should just write in a very sort of clear, straightforward method, so the people who are reading it can at least understand what's there.
I think that's a really, really important point. And, you know, Sarah Carr, who's read a lot of the qualitative research that we blogged about on the mental health and social care health, we've spoken about this a few times over the last few years, haven't we, Sarah, that it's often impenetrable. And this is why science blogging, I think, is so important. Actually, it might be important research, but it's impenetrable.
Yes.
Yeah, sorry.
No, absolutely. I mean, I when I was thinking this through, one of my criteria would be, are the findings useful? But of course, are they intelligible? They might be useful, but we can't dig through some of the kind of the language in order to find what's actually really valuable to policy or practice. And kind of expanding on that a bit, particularly in some of the more social care qualitative research journals where mental health research pops up. Over the years, I've been frustrated about the quality of just the reporting, the methodology, how clear that is. You know, you need to know how a piece of research was conducted. You need to know about the research ethics that were considered. All those things that you need to know, whether or not this is a piece of reliable research, sometimes are quite poorly reported because there seems to be a race to get to the findings, but you can't judge whether or not those findings are reliable because there isn't sufficient information to judge how the research has actually been conducted.
Yeah, Trish, how do you do this at BMJ Open? Because as you say, you published a lot of great quality stuff there. Oh, I think you're muted. Sorry, can't hear you, Trish. Can you unmute? No, you've been silenced. Oh, how frustrating. Douglas, can you help? Maybe somebody else would like to come in on this.
I'll say a few words.
Yeah, thanks, Alan.
I think there's a lot of sense has been spoken about the importance of things being written clearly, and most importantly, a good description of the methods. And I think too often in the past, qualitative papers, authors have not taken sufficient time to spell out exactly what was done, so that other people can get a good idea of whether that was done in a structured and meaningful way. There are a number of good guidelines out there for producing and reporting good qualitative research. I was part of a group many years ago with Clive Seal, Alan Quirk and some other people, and we produced some guidelines for the British Journal of Psychiatry, which I checked last week and is still there on their website under the guidelines for authors. And there are many of those around. For me, one of the big issues, as well as the methods, is often being, I think too often, some qualitative research is under-analysed, and that can be a concern, that too often people are producing stuff which almost reflects the questions asked and not much more than that. And I think there needs to be a much stronger, people reviewing work need to be much more prepared to go back and ask for more, really. That a higher level of analysis needs to be undertaken before it's published. But I'd say that's not always, but it's quite often smaller studies, I think.
Yeah, I think the point that Trish was trying to make was about core Q, so the consolidated criteria for reporting qualitative research, which is a checklist for qualitative research, interviews and focus groups. It's available on the web. Maybe Douglas can tweet a link from Mental Health to that. It's on the Equator Network website, which has a lot of these quality criteria and checklists for standards of research. It was published back in 2007. Yeah, thanks, Trish.
I was going to mention the same reporting guidelines. I think that helps to a certain degree, as Sarah was saying, about, you know, more, as you'd expect for any study, really complete description of the methods and the selection of study participants and the intervention and so on. I found, being associated with funding boards, that in a way the good qualitative research tends to be very good and the bad tends to be very bad. And I think it's kind of interesting. I think it's something about the role of the senior investigator is very important, perhaps more important than in a more quantitative study, where there's perhaps more of a template for a study protocol. And there's something about an experienced study investigator will bring content knowledge, will be able to kind of negotiate the relationship with study sites and participants in a different way, but will also, and I think we've touched on this before, I think the very good qualitative research by people like, I know, Mary Dixon Woods or Trish Greenhalgh, there's something about nothing as practical as a good theory. So I think Sarah was saying about how impenetrable some articles are, and sometimes that's because of very dense, perhaps not good use of theory, but there's something about theoretically informed qualitative studies which are really helpful, because it's then a frame both for the analysis and discussion and for actually selection. I mean, if you're doing organisational case studies, you're not necessarily looking for a representative sample. You're looking for whatever your theoretical sampling frame is for what the kind of area is of interest. So there's something about the good use of theory, and it's something about a lead investigator and the write-up that is compelling and experienced.
Yeah, thank you. Well, so if I'm a student or a practitioner and I'm not very familiar with qualitative research, what would be a good starting point in terms of critically appraising a paper that I'm reading? What would you suggest? You know, if you have to give people 3 questions they should ask of the paper, 3 things they should look for to say that it's high quality, what would you suggest?
I think some of it's Ema here. I think some of it's already been said. You know, is it clear? What is the meaning? What do the results mean? Is it useful? I mean, if it's about practice, if it's useful for practice, does it extend knowledge? One of the things I find with qualitative research that maybe the middling stuff that isn't brilliant but isn't terrible, and you know you're reading it as a publication, is that it isn't. It's like a brick of data that means something, but it isn't building the body or the edifice of knowledge. So we've learnt something about something that could be seen to be meaningful, but I think that qualitative research, and any research, but certainly research, has to be building knowledge somehow, not just finding one particular perspective on something. So it has to be evaluated against everything else around it in terms of the evidence. And I don't think we often see a lot of that. Often it's the finding is the finding in itself, and I don't think that's always enough. It has to be explicated to be useful, otherwise it is just navel gazing.
Yeah. What have the 2 Sarahs found when they've been reading papers and blogging about them on our wonderful website? What have you done to quality appraise them?
I think you know, again, I look for as thorough a description of how the data's been collected and rationales for that, you know. And so, for example, as discussed, it may not be, well, it often isn't that you're going for some kind of you know, generalizable representative sample. You may have a very theoretical framework, and I think, you know, look for that being explained and justified. That's what you're after. And then I think in the details about the analysis, and then really in the data itself, you know, I guess what's unique with a qualitative paper is that in a way you are presenting the raw data, your extracts of raw data to the reader, and then it's about, you know, have you framed those, have you shown what you're adding to those either in your interpretation or how that builds on a theory that you're discussing. And so I think you're looking then for a narrative around that analysis and the presentation of the data, rather than just, here are, you know, 5 quotes where they all mention the same thing, and then conclusion is people mention this a lot. You know, that's the kind of stuff that you want to get away from, and I think relates to the point about, you know, doing proper theoretical work, and that is really one of the strengths, but also challenge of doing good qualitative work.
Sarah, anything to add?
Yeah, I mean, I definitely agree about the good, strong theoretical grounding, and also sort of simple thing of ascertaining whether or not a study is original. Does it have anything new to say about a topic? So looking at a paper for something as simple as a literature review, where does it situate itself within the existing literature? How does the existing literature inform the question, the investigation? And I know that I blogged on one paper on service user participation for the mental health. And yeah, I didn't seem to say anything original, and there are big chunks of literature missing in the literature review and in the conceptualisation of the question and the study. And I thought it was worth blogging on that, just to show that, just to highlight that as a difficulty in some qualitative studies. And the other thing that I sort of tend to look at is kind of the top and tail bit as well. What claims are the investigators making for their findings in relation to what they've actually done and who they've actually spoken to? So are they sort of slightly suggesting these findings can apply to groups of people who they haven't spoken to? So looking kind of at the end as well about the conclusions in the discussion, going back and asking, well, have you answered your own question in the investigation? and what claims are you making for your finding.
Great, thank you very much. Let's move on to our final question. We've got 10 minutes to go. So I wanted to ask about mixed methods research. It's something that's been mentioned a few times already during the call. Would anybody like to describe what mixed methods research is and what they think, or how they think it can help improve mental health care? It seems to be something that's much more popular over the last few years.
For me, mixed methods research can be used in a range of different ways. Qualitative research can help us explore a relatively new topic where there's not a great literature base, and inform questions to then be explored, investigated using quantitative methods. Qualitative methods can be used to help us understand quantitative findings and explain some of the processes that might have gone on to explain results that we have. Sometimes results which are contradictory, or contradictory or confusing, and also sometimes enables us to triangulate, collecting different data, using different methods to explore what I would see as in more depth this phenomena under study. So I've used that myself a number of times, where by collecting quantitative data from people, survey results, but then also observing, asking people about what they're doing, what they think about what they're doing, and so on, it helps you get a broader understanding of what the real issues are. Sometimes reveal stuff and helps you understand some of the dynamics much more than you would have done if you just used one method.
Great, thank you, Alan. Anybody want to add to that?
Yeah, I mean, I'd agree with that. And one of the things that I've sort of picked up from our discussions is the value of mixed methods for understanding the systems and organisations into which interventions are being introduced. So often, I mean, I'm thinking about the introduction of personal budgets and personal health budgets in mental health. You know, that there are a whole range of issues that need to be considered, because mental health services mental health is a complex thing, and mental health services are complex things. It would be much more, you know, a qualitative approach would be a better way of finding out what's going on. So about staff attitudes, behaviours, organisational cultures, you know, all these things that come up time and time again. Yes, this should be able to work, but it's the organisational culture that's causing difficulties. So, yeah, I think, you know, qualitative investigations of attitudes and cultures are important to complement trials.
I think that's a really good point, that qualitative methods can enable you to explore the different levels of the thing that you're studying. So the macro, the meso, the micro, and identify some of the factors that impact on other factors. And that's an incredibly useful thing to be able to do.
I think I just tweeted, actually, there was a paper in the BMJ actually, which I wrote up from a round table, which was a number of funding bodies, the NIHR, the HSDR program, the CLARCS, the MRC, the Health Foundation, and the Universities UK, just looking at how new methods for evaluating complex systems and services. And we give lots of examples of mixed methods research, because it really, I mean, it's hard to see actually when you wouldn't want mixed methods. And it's, as Alan was saying, it's about triangulating your sources. So for instance, within the NIHR portfolio, we've got a big study on liaison psychiatry services, and it's also echoing Alan's point, it is trying to get at not just the meso level service, but then tracking individual patient journeys, so going to the patient level, and doing quite a lot of complex secondary data analysis to understand what happens on those journeys in terms of process and outcomes. and it's it's a really complex program of work, but you need all those parts to really understand what good looks like, I think.
Yeah.
And what about a qualitative part of a bigger study that has quantitative? So I'm thinking about the REACT study, Sarah, that you worked on, where you did the qualitative work. How does that work from the perspective of a qualitative researcher who goes in to work on that sort of study? So this is a study of online CBT for depression.
And I think sort of quite a lot of my qualitative work has been nested within trials like that, and I think they are really good examples of how mixed methods is a complementary approach and a very pragmatic approach to sort of saying what's the most useful messages we can get out of this. So in REACT, for example, you get the sort of the hard outcomes, which were depression symptoms at the end of the trial and uptake of a computerized CBT platform. And then really the qualitative work was explaining those numbers and putting those numbers in context and giving us also directions, I think, to, well, what would need to change to engage people better, for example, with therapy, what were the issues that affected. And in the trials, it's been the qualitative researchers answer those questions around context and organisational complexity, and they're looking at implementation. So the trial is trying to look to a degree at kind of for a pure outcome, and then the qualitative work can say, but where is this actually situated and what other factors impacting it? And that, I think, has really valuable lessons then for kind of, well, if the trial shows the treatment is effective, great, but how do you roll that treatment out? That kind of question is where the qualitative research, I think, comes in and has the answers.
I think just to pick up on Sarah's point there, if you're looking about mixed methods research and how it can improve mental health care, I think without mixed methods research, the question which seems to be asked, in the past all along has been what works. I know this is probably Tricia Greenhalgh's phrase themselves, but if the questions we should be asking are what works for whom in what circumstances, we can't do that without mixed methods.
I think it's interesting then how I don't know. I think sometimes when trials get a null result they weren't expecting, that's when they tend to perhaps lean a bit on the qualitative research to explain why that happened. And then that's actually the stuff that will point in the directions for what we should do differently. So. Is
that what happened with REACT? Because the results there were fairly disappointing. The follow-up was fairly disappointing.
Yeah, but I think so. I think qualitative research showed that it wasn't so simple as people just didn't like it and didn't use it. There were real differences between who liked it and who didn't, and then what you could do to improve that experience of people, and for kind of informing what we call the next generation of those technologies. REACT gave you the bold statement, and then the qualitative work fills in the details, and I think we all know that the devil's in the details. That's actually where a lot of the key points are.
Yeah. Okay, we're out of time. It's been a really fascinating discussion. So thanks very much to everyone who's participated. It's been a real treat to get you all on the call. Thank you for your time. And I just wanted to say we've got about 1,500 blogs on the mental health and the social care health, and I think over 200 of them about qualitative studies. So we've certainly blogged about a lot of qualitative research in mental health and social care, and obviously we'll continue to do that wherever it's published. And also to say that the next campfire is on the 25th of May. It's about Ritalin for ADHD. So a bit of a change from this month's topic. But thanks very much to everybody who's watched and participated. We'll see you next month.
Thank you.
Thank you.
Thank you.
Thank you.